Colleagues, thank you. Thank you so much for joining us for this discussion on racism in context of global health. The panel, whom I will introduce to you in a brief moment, would reflect on different ways in which racism interacts with global health and identify issues related to racism within global health, and also how racism is being perpetuated through global health. In her report to the United Nations General Assembly, the UN Special Rapporteur on Right to Health proclaimed, "The right to health cannot be realized in a racist world." Recent evidence points to biases and abuses faced by minoritized people across the globe and highlights diverse pathways through which discrimination harms health. Racism affects global health in multiple ways and through multiple manifestations. It starts, as some have pointed out, to the very definition of global health and how we understand global health to what it has become. For instance, writing for the Nature Medicine Journal, Jacob, Olusanya, and colleagues pointed out different ways in which racism is perpetuated through global health. Jacob and colleagues pointed out that the predominant concept of global health evolved as a humanitarian rescue mission to the global south by philanthropists, charitable organizations, and public health experts in the global north. The paternalistic origins of global health has been fostered through a power structure and a culture of supremacy that considers prior consultation with the beneficiaries as unnecessary before decisions are made on health interventions to offer, pointing to the imperative of involving people of color living in different parts of the world in setting priorities on research, on policies, and program. The question we really need to be asking ourselves is, why is that in 2023, this is still not happening? The World Health Organization has acknowledged that across the globe, indigenous people, as well as people of African descent, Roma, and other ethnic minorities experience stigma, racism, and racial discrimination. The situation, according to WHO, often increases their exposure and vulnerability to risk factors and reduces their access to quality health services. The result is that these populations often experience a poor health outcome. The effect of this, however, starts in early life. In a statement on impact of racism on child and adolescent health, American Academy of Pediatrics in 2019 noted that racism is a driver of health inequities and that failure to address racism will continue to undermine health equity for all children, adolescents, emerging adults, and their families. Strategies, therefore, to address health and development issues across pediatric lifespan that incorporate ethnicity, culture, and circumstances are critical to achieving health outcomes. As Dylan Devkumar and colleagues recently pointed out, that the pandemic, COVID-19, uncovered social and political fractures within communities with racialized and discriminatory responses to fear, disproportionately affecting marginalized groups. Political leaders have misappropriated the COVID-19 crisis to reinforce racial discrimination, doubling down, as he and colleagues pointed out, for example, on border policies and conflating public health restrictions with anti-migrant rhetoric. The World Health Organization has repeatedly highlighted that this has been evidenced and exacerbated during the COVID-19 pandemic, in which some of the starkest inequities have emerged among populations experiencing racial discrimination. Furthermore, evidence points to the intersectional impact racism has when combined with other factors such as gender, inequities, and religious discrimination, both in terms of individuals' ability to access health facilities, goods and services, and ultimately impacting their health outcome. Repeat calls are therefore made to recognize racism and xenophobia as fundamental determinants to implement measures that focus on addressing the structural causes, however, have met with very limited success. The question we should be asking ourselves, why is that the case? The panel that we have today will reflect on some of these issues based on their work with government, academia, multilateral agencies, and beyond. And with this, it is my great pleasure to introduce our three panelists. Assistant Secretary for Health and Human Services, Ms. Lois Pace, Delan Devkumar, Professor at University College London, and Dr. Anna Amaya, Associate Professor at Pace University in New York. They all have very rich bios and very extensive experience working on these issues for the last several years. I would ask them to briefly introduce themselves as they take the floor, but I would turn first to you, Ms. Pace, for your framing remarks. And if you could reflect on the issues of racism in global health from your perspective as the Assistant Secretary for Health and Human Services. And also if you could reflect for us power structures that underpin racism in global health, and what do you think is the responsibility of the global health community? Over to you.
Very small questions.
This one.
Yeah, let's do this one. Yeah, thanks for giving me the easy job. I really like how you started. Hi, everyone. I was here earlier. It's good to hi. I see people I haven't seen in a long time. I really appreciate how you started, right? Because one of the things I was reflecting on racing over here was one, how do we get here, right? Like, how is racism and global health a thing? Well, it's because racism is a thing, obviously. And at some point, the world just didn't care about certain people. That's just the reality. And then at another point a little bit later, where I think you picked up, right? They said, oh, we care very much about these people and we will help them. We have all the answers, right? So you're welcome, people. And then and maybe now I feel we're in a state of acknowledging that it's not cool to not care about folks, and then also not so great to tell them what to do. But there's a real discomfort with what actually needs to happen, which is to flip the table in many cases, and you potentially start from scratch. So that is, I mean, I don't know, at some point, I think in our prep, we were talking about asking tough questions or having the hard conversations. And, I remember in the position I had before now, one of the things that I was told is, well, Lois, how can we really go about dismantling, decolonizing, democratizing global health without changing all the things that make it great, right? In other words, especially in a country where we're fighting for every dollar and cent, you're putting everything else at risk. And so there's this real comfort and even sense of obligation to the status quo because of all the harm it might do to change all the progress we've made or dial back the progress we've made. And that's just a real question and conversation I still don't think we've had, at least not in the US global health community. And perhaps I'll let others speak to what that feels like outside of our borders. So it might be very surprising for people to hear someone from government say this, but I just think that, again, it's just that's my personal reality and experience that it seems is shared by others with whom I've worked even now. That said, and this gets to the second part of your question, we do have an obligation to ask those hard questions and to, of course, be responsible in how we go about trying to pick this apart. But the reality is, we're going to continue to fall short of these lofty, not so lofty goals, but really important goals that we have if we don't truly stare in the face the racist and discriminatory practices that still exist in global health and in development broadly. So, you look at, for example, I mean, you don't have to give many examples. We had a recent one with COVID, right? Where we still had people who weren't able to access innovations at the rate of others. We had Black and Brown folks being denied entry, even when people who didn't look like those of us here were not questioned in the same way. That's racist. And we have to say the quiet part out loud and ask ourselves why that is, but also actually do something to address it. And that gets me to what I think is an important kind of way to start to work through this as a government, as an organization, as, you know, as a stakeholder in this space. First, you have to say the thing, which is still not something everyone is comfortable doing, right? I mean, I've been in plenty of settings where, you know, people have not been happy to hear me speak as candidly as I'm speaking now. And I think it's, you know, it's hard for folks. It's, you know, it can be uncomfortable, that it can be unfamiliar, but regardless, it's not doing us any good to sort of talk around the problem. And it's not DEIA, right? It's not diversity, equity, inclusion. Like, this is not the same thing. And I think that's an important distinction to make. But we have to say what we're talking about, and we have to say it very clearly to one another, whatever the context. We also have to see it for what it is. And what I mean by that is, you know, really picking up the pen and measuring or documenting kind of how it manifests. And that's why I am grateful for, you know, what the Lancet has done with people like Prof. Devakumar, or other, you know, similar efforts I know are upcoming. Unless we actually see it for what it is and help people understand beyond, you know, decolonizing or an anti-racist approach, kind of what steps they need to take to address it, then, you know, we won't get there. But that's the third piece. We ultimately have to solve it. Because again, like, we talk about the last mile, and we talk about all these, you know, these ways that we probably won't reach the 2030 goals, but it's not yes, it's about resources, surely. Yes, it's about, you know, sort of compound crises. There are a lot of barriers to reaching these goals, but another important barrier is racism and discrimination, structural discrimination in global health. And that cannot be left out of all of these dialogues, all of these forums, all of these calls to action. And I will be really grateful if and when we are able to lift up this particular factor in all of those settings, in the same way we talk about raising, you know, millions and billions of dollars, or mobilizing millions or billions of people. That's what I think.
Thank you. Thank you so much for that. What is important is what, as you stated, you know, we need to start by acknowledging we have a problem, and we need to start talking about it in a manner that we have. I have to tell you, the number of times I've tried to have these conversations in Global Health Forum, I've been actually reminded, you know, we really don't need activism right now. We need to focus on the technical bit. And I don't know how one separates that, and why there is the discounting of something that is so systemic, as Dylan and his work will show, which is impacting people in multiple pathways and through multiple situations. And when would be there a time to talk about issues related to racism, xenophobia, in context of global health? Very lucky to have you with us, Dylan, and thank you for joining us and for sharing us the findings of the Lancet Commission, a series on racism and xenophobia, but also your reflections on where are the gaps and how do we go about it.
Thank you, and thank you very much for having me here, and I appreciate your words. I'm going to talk a little bit about the Lancet series that we published in December last year. This was a 4-paper series covering very broadly aspects of racism, xenophobia, discrimination, and how it affects health populations around the world. I have some slides. Roger had asked me to summarize the series. There's about 25,000 words, which I'll try and do in 10 minutes, so I'll be speaking very quickly. When I started this, so this was in 2019, when this was a time before COVID, before the Black Lives Matter movements, where really there wasn't much talk about these issues within health context, within the kinds of spaces that I work in. So I'm a medical doctor, formerly pediatric doctor, and then public health doctor. And one of the big things I wanted to do was just to put this on the agenda, put it on the agenda within the kinds of conversations that people have, whatever they do, whether they're a clinician doing frontline work, whether they're in a university like I am. So to think about it alongside these other big determinants of health, because racism, xenophobia, discrimination is one of the major determinants of health, of morbidity, of mortality of populations around the world. And then to put it as a global health issue, because it goes beyond the places that I live in. I come from the UK, beyond the United States. This is something that happens in every society, everywhere around the world. And there are similar forms of discrimination which play out, and be they on the basis of religion or someone's migratory status. There are different histories, different cultures, different contexts, but there's a similar process, a process of othering people, of demonizing people, of minoritizing people, so taking away economic, social, political power from people. And then to talk about it in a structural sense. So we tend to think about interpersonal acts of abuse or violence. We don't think about what lies underneath. So within the series, we looked across the board and we focused on the individual up to this kind of social and political. So when you think about the individual person, there are many different pathways by which racism can lead to ill health through behavioral changes, physiological, psychological changes. There are these ideas of stress or toxic stress, of allostatic load, of weathering, these ideas where your hormonal systems go into overdrive, these neuroendocrine responses, which result in poor health outcomes. COVID-19 was mentioned by both speakers, and if we look at the United Kingdom, the Office for National Statistics looked at mortality amongst minority groups and found that Bangladeshi women had a 4 times increased mortality compared to white women. Bangladeshi men had a 5 times increased mortality. And this is complicated. Why that happens goes from the individual responses up to structural and barriers to healthcare that they face. So we kind of summarized the literature around health, and this slide really isn't for you to read, but just to say that there are lots of health outcomes at all the life stages, from young children to younger adults to older people, and intergenerationally for how it affects the next generation as well. So then we thought about those people, those individuals within the context that they live in, the communities that they live in. And those communities can work in different ways. They can support and protect individuals. They can provide communities that physically people that live in, but also increasingly with technology, those communities can be spread around the world. But those communities can also work in the other way. Those communities can oppress people. And there are numerous examples in every context, including right here in the US. We then thought about the spatial context that people live in, the environments that people live in, and how that affects health. And that can be, as was discussed earlier today, mining, and how that the chemicals that's released from mining processes and extraction can affect indigenous communities. It can be where I live in London, air pollution, and how certain populations are exposed to much higher levels of air pollution, and those happen to be minority groups, particularly Black populations, South Asian populations, and they are exposed to much higher levels of air pollution. Children are breathing in toxic air, even in cities like London. What we tried to do was put this conceptual model within a sort of an idea of a globe. And where we think about the individual person, really the causes are structural. These are the things that lie underneath. And we brought in these ideas of separation and hierarchy. Across the world, populations are separated into different groups, but then importantly, hierarchies are placed where certain groups are placed above other groups. And these go back to the 1700s, these traditional concepts of races, Karl Linnaeus, Johann Blumenbach, and these concepts have progressed through the centuries, and we still talk about races today because these groups are still oppressed, because these hierarchies are still in place. And then thinking about the pathways through that happens, there's the systems, and then we separated off the health system in particular, considering the health outcomes that we're talking about. So if we look, I think there was a slide missing. So if we look at the health systems in particular, there are numerous ways in which the health system can contribute to ill health. There can be physical barriers. So in the UK, we have this thing called the hostile environment to it came in under the Conservative government recently to deter migrants from coming to the UK. And this idea has multiple ways in which it plays out, but one is through the health system, where migrants are charged for access to the health system. And this is in a country where we have the national health system that's free at the point of access, something that's exalted within our country and in other countries. But there's this barrier for migrants who come to the country. And other things can be, less deliberate. It just can be the way that the health system is set up that excludes certain groups from other groups. It excludes certain health workers, and we see different attainment levels for different minority groups of health workers. So then we put all that together into this conceptual model, and we put this timeline around. So I'm a child health doctor, and I think about how racism can affect children at different stages. There are sensitive parts of the life course that give different outcomes. Also, adolescence is another key area. And then what we did was we tried to invert the usual social ecological models. Rather than having the person at the center, we put the person right on the outside, because really it's these structural causes that are the drivers of what happens. And my colleagues can speak very powerfully to that after. We then looked at intersectionality, and this is a crucially important concept, and how individuals have multiple identities and multiple things going on. So it's not just someone's race or ethnicity or religion, it's a combination of all these things. So we looked at case studies from around the world. We took the key messages from across these and looked at all of them together. And we saw this idea of history and colonial legacies that still play out in today's health disadvantages for populations. The idea of violence being within a system that ultimately results in physical forms of violence, psychological forms of violence that people face. And then the kind of institutions and the racism that's embedded within institutions that take place. And then we try to look at what can you do? And the answer really isn't simple, but the answer is sort of, we have to do everything everywhere. So this multi-sectoral approach where we focus on the individual. So there are individual interventions. They tend to be not very effective, but if some of those interventions can be sustained, but then looking at the health system, looking at the other systems that can affect health, looking at these structural causes, the way societies are governed, the laws that govern societies. And then finally, we had these 6 actions, idea of decolonization, justice, genuine diversity and inclusion, intersectionality, anti-racism action, and a human rights approach. And here I suppose I put the question to you as to how do you do these things? What does decolonization mean? How can you enact decolonization? How can you look at genuine justice approaches, looking at epistemic forms of injustice? Who is listened to? Who appears on a panel here? Who isn't here? Thinking about diversity inclusion, not just a tokenistic approach towards diversity inclusion, actually including people from a young age throughout their schooling, education, and into professional careers. How do we include the many factors, including issues of gender, abilities and disabilities, age, and the many other forms of identity that people have, and take anti-racist action that is difficult. And as you say, Lois, that you might be persecuted when you're saying those actions as well. And a human rights approach, and I would defer to Rajat in particular. How can we take this sort of legal approach to health? And then finally, just to flag up our website, where we try to do some of these issues, and we try to educate, advocate, to disseminate some of the messages from the series. Thank you.
Thank you very much, Dylan, for that. And congratulations, really, for all your work on it. And I know it doesn't end with this, and I hope in our conversation moving forward, we are able to reflect and go deeper on some of the issues that you talked about, but also, something that you reminded me. In 2008, I worked on a report looking at birthing outcomes in Black women and women of color in the United States of America. It's one of the worst maternal mortality rates in any other comparable country in the developed world. Unfortunately, the 2023 data is much worse than the 2008 data that there was. And there is something clearly happening here, which is systemic, deep-rooted, and it's not being addressed in any manner whatsoever. But it also forces us to think about frameworks that are not working and challenge ourselves to think about what would a justice-oriented approach to address these issues look like. And I hope we are able to unpack some of these issues as we come to the panel discussion, but also conversation with the audience. And with that, I'm very pleased to welcome you, Anna, again. And thank you really for joining us and sharing with us your reflections on inequitable decision-making at the global level, which is, as you described, both a reflection and cause of racism. Over to you, Anna.
Thank you, Rajat. This is working, right?
Yeah.
Perfect. Well, thank you for the introduction and also for the organizers for inviting me here today. It's really nice to be in a panel and see colleagues in person, finally, after many years of being apart. And also thank you to those joining online. So my research primarily looks at decision-making at the global level on health and its impact on low and middle income countries. And as all of us know, what happens at the global level has real manifestations in the barriers of health faced by people subject to racism. Racism is a pervasive problem in global health decision-making, and it has far-reaching consequences for public health. It manifests itself in the form of unequal access to healthcare, inadequate funding for research and interventions, as well as discriminatory practices and policies that exacerbate those health disparities. So in my work, racism, xenophobia, and discrimination as causes and reflections of inequitable decision-making have really emerged as a clear theme, and this is primarily what I'll be discussing today. I'll be focusing on three key issues that, in my view, need to be addressed both at the institutional as well as at the structural level to combat racism in global health. These are, number one, being much more explicit about how we approach anti-racism interventions. Number two, ensuring equitable decision-making and representation in global health discussions. And the third is rethinking how we fund health at the global level, as this is a manifestation of what the global community actually values in health. So my first point relates to how we must be much more explicit about addressing racism if we want real change. As we know, structural racism is manifested in laws, policies, and practices that limit access to healthcare for certain populations. And as the panelists before me have discussed, to address racism, we also need to consider the intersectionality as well as the effects of these overlapping systems of oppression. However, diversity, equity, and inclusion initiatives, of which we hear a lot about these days, still put most of their emphasis on addressing interpersonal racism rather than the causes of racism. This is, of course, unsurprising because it is much easier to place blame on individuals rather than invest in addressing the root causes of racism, which obviously take time, investment, as well as self-reflection. At the international level, we see institutions like the UN that are undergoing these processes of understanding the gaps in how racism is addressed within its various institutions. A recent review of measures for addressing racism within the UN found that given the absence of a clear working definition of race and racism, the institution is unable to deliver effective oversight and accountability on issues of race and racism internally. This obviously has clear repercussions, not only at the UN, but also brings to question how this may have effects on the very initiatives they are trying to implement. While this is concerning, understanding these gaps is a really important step in developing appropriate processes for addressing racism. And so there is still much work to do in this area. There are clear signs of progress. There is still much more we can learn about how other issues have been addressed at the institutional level and use some of those lessons to make significant progress to address racism. So my second point relates to addressing inequitable decision-making and representation in global discussions. During COVID-19, we saw that many of the people who were disproportionately hurt by the virus had the least control over and say in the system. This was especially the case for minoritized communities, which were already experiencing health and economic crisis before the pandemic. This has not only been an issue of financing, but also the inability of the international system to ensure equal access to vaccines and other supplies that were needed to fight the pandemic. Even before the pandemic, we were aware that negotiations and decision-making at the global level are still very much dominated by the interests of high-income countries, and COVID-19 only highlighted those power differentials, both at the global level, but also regionally and locally. We can't expect real change in the ruling paradigms around global health if we aren't addressing those structural inequities in representation and participation at the top. Addressing this is important because given the lack of a singular authority above sovereign states at the global level, we know that global health policymaking frequently takes place through consensus. So in this context, inequities in power and influence, along with the capacity to participate in global health diplomacy, means that some actors can shape global health policy much more effectively than others. And obviously, this puts low and middle income countries at a clear disadvantage. We're also aware that research has found that the history and the structure of the international system has itself legitimized and stratifies the system of political equals and unequals. So it is within the hierarchy of the system that really limits the lofty principles of equality and morality. We don't need to look much further than the Security Council at the UN, where we have permanent members that have the veto powers versus the second grade members. And in addition, in global health, we've obviously gone through several periods of discussions where the rhetoric has focused in primary healthcare, universal health coverage, among other issues. But no real change has come about because we are still working in the same ways. And this is very much a reflection of who is on the table, making the decisions and developing the priorities. So my third point is around funding interventions and research to improve access to health among communities experiencing racial discrimination, as well as examining what we currently fund and how that shows where we place priorities. A crucial part of addressing racism involves funding interventions that ensure communities experiencing racial discrimination have access to comprehensive, culturally appropriate, and quality health services. We know that there is not only less funding for interventions that address minoritized populations, but also there is a lack of research overall on this issue, and even less research conducted with marginalized populations themselves. There is a significant need for empirical studies on the relationship between health and racism. And for this, we need to collect evidence that captures the understudied aspects of structural racism and do so in collaboration with the affected communities, considering as well the local knowledge. This issue is also reflected in the production of evidence. The global health research agenda has historically been dominated and led by funders and experts from the global north, with a 2019 study reporting that only 19% of global health publications actually include authors from low and middle income countries. And when funding does exist, we also need to make sure that this is allocated towards these goals. We have high expectations for the WHO, but realistically, the WHO's annual budget is less than the budget of many major US hospitals. And for a point of comparison, it is about 1/5 of the CDC's budget. At the same time, the share of tied funding is also quite high, with membership dues from countries representing less than 20% of the agency's total budget. And of course, this limits the work that the WHO itself can do. The other part of increasing funding is for countries themselves to increase public sector funding for health. And what we see right now is as low-income countries transition to funding much more of their health budgets, they will require external financial support from high-income countries. And this support should be equitable and fair. And this is not an issue of charity, rather an issue of justice. High-income countries should recognize the benefits they have accrued over time through, yes, colonization, as well as through the global economic system. And when support is given, this should be logical and respond to the interests of countries. It doesn't really make sense to have to support an mRNA hub in South Africa, for example, when intellectual property barriers to produce such vaccines are still in place. So related to this, we must also examine the impact of the economic decisions on groups experiencing discrimination. We know that austerity measures most significantly impact people from marginalized groups, including racial minorities, indigenous peoples, as well as other population groups. For example, a report by Amnesty International, as well as research by McKee, Stuckler, and others, have found that the austerity measures that were put in place in several European countries in 2008 led to cuts in public sector jobs, many of these in health, as well as a spike in the number of the unhoused and an increase in suicide rates among communities experiencing racism. So just to finalize, because I know I have limited time, we need to work based on the current reality and also strive towards incremental change, because this isn't going to change overnight. We need to see how we can take advantage of current events and the current attention on global health to change mindsets as well as structures. And certainly a time of crisis can also be a time for transformation. And it'll be important to see in this time whether new forms of working will emerge or whether existing ones will be reconfigured. So thank you, and I look forward to the discussion.
Thank you. Thank you very much, Anna, for those remarks. And bringing in the multiple facets of the issue out so clearly in your presentation. The recent OECD report points out, and Sarah Champion, the UK House of Commons chair of the Select Committee, in her essay in the OECD report, remarks that global development aid is fundamentally racist. Mm-hmm. And to fix what we need to do, we need to have a review of what we think about global development cooperation and what needs to be done about that. And there are no easy answers, because I think what is happening is pretty systemic and rather endemic at the same time as well. You very rightly pointed out the issue of intersectionality and the publishing data that you pointed out as well. There is a recent review done by the British Medical Journal in which the authors who reviewed the publication during COVID-19 point out the complete asymmetry between authorship, and this is where the intersectionality become very much more important, because if you look at it from gender and racial perspective, you have none. You actually have women of color being completely left out. And I'm sure if you even look at women as a category overall as compared to men, there is a very systemic marginalization of how the publishing trends picked up in those 3 years. Which brings us to the point, to the panel discussion before opening it up to our audience, is, so what do we do about it? Mm-hmm. And where do we go from here? And if I may turn to each of you in the same order, if you could reflect on some of the measures and actions that you think should be taken at the national level, at the local level to address these issues, but also what do you think needs to be done in terms of raising awareness at the global level to affect the change that we seek to achieve? If I may start with you, Lawrence.
Yes, you may. I want to thank you for even having this discussion today, but frankly, being someone who's been out there on this topic. I think these types of convenings, and obviously publications and just speaking the truth is how we raise awareness, and importantly, making sure that it's not, me saying it, I'll speak for myself, right? But these communities themselves are given the platform to share their direct experience with this, right? Let alone the solutions for how we resolve it. So I just want to create and keep space for that, because I think that's an important component of that awareness raising. In terms of kind of how we go about solving it and really kind of measuring and addressing the problem. I'll talk a little bit about what we're doing as a government. Early on in this administration, there were a number of what we call executive orders issued. And one of those executive orders was actually explicitly around sort of addressing ways that agencies across our government attempt to advance racial equity. That still feels like a big deal to me, that our government would step out and first off acknowledge the role that it could play in racism and the opportunity we have to advance racial equity explicitly and anti-discrimination. And so the point of that was really to, look across all of the various government activities and again, understand the ways that we can better support underserved communities, how different parts of government were attempting to do that, ways that they've sort of iterated over time. And actually our, again, this is out of the White House, so the Office of Management and Budget issued a report several months later, really giving us a sense of what they found so far. And I think they plan on doing more in this regard, right? Because this is not sort of just a one-time assessment. But what's really helpful about that is first they said, okay, there are a number of agencies who say they're trying to solve this, but their data is a bit apples and oranges. There's some who are looking at the distribution of resources. There are others that are looking more at impact or outcomes. And so how do we kind of reconcile those differences? Both are arguably important, but I think, there are people who look more closely at this who can say, which interventions might be most effective. There was another clear directive that we got from that reporting that talked about our procurement practices, right? And we've heard, agencies like USAID already talk about the importance of how they award grants, or even I think in the planning process, kind of set organizations or institutions up to receive those resources. To be clear, we haven't yet solved this problem, but I think it's encouraging that across government, you have huge departments like the Department of Health looking also at, its contracting and procurement and grant making, and really ensuring, again, they're combing through those with a racial lens and being very explicit about that, let alone looking at other factors. I'm talking about racism because that's our topic now, but we know how much affects sort of our work, right? Homophobia, gender discrimination, and the like. And then finally, one important outcome of that report was really acknowledging how much it will take to change culture inside a huge bureaucracy like the United States government. Let's be very clear and honest about that. And so this is not even just the work that can happen in one cycle, right? But it needs to continue. So I think there are ways that we can try and embed that type of change management so that it is sustained. But that is very much the work. And I think that is where the hearts and minds come into play, where it's not just individual action, but certainly, or arguably, I won't say certainly, there's an important role that individuals that then collectively play to then move this along institutionally. So hopefully I answered your questions.
Yes, indeed. Thank you. Thank you so much, Dylan. Over to you.
Thank you. I mean, I think I'll start by saying I don't know the answer.
Yeah, right,
That's my base. And there's no single answer. And maybe that's obvious, but that probably has to be said as well, that this is a difficult topic. We wouldn't be having this session if there was a simple answer. One thing I might go back to is that conceptual model and those different layers. And we probably have to do something at all those layers. And my feeling is that those individual interventions, and it tends to be individual interventions, thinking about sort of clinical or public health interventions, they don't work very well. And that's not, none of them work, but on the whole, they don't work very well. But they tend to be quite short. They tend to be, do this training and then you will not be racist anymore. And, those kinds of mentalities. Coupled with that, we probably don't know as well, in that the evaluations of those interventions are not great as well. So they tend to be short evaluations soon after the intervention rather than longer term. these are difficult societal issues. So are we measuring the right things? Do we know how to measure the right outcomes? So even the evaluations are not great. I think the more powerful interventions tend to be the ones that are upstream or at the core of our model. Can you change a system so that it's not structurally racist in different ways? Can you, support people who maybe drop out of, think about health worker progression. There are different rates of people who drop out, different pay progressions, different attainment levels in exams, and many different things. So can you support those groups who don't do so well when obviously they should do the same? And then to the core of the model, and this is where all three of my colleagues are much better placed than I am to think about those legal interventions, those political interventions, how government can be structured, and that's really where the heart of this lies and where you can make big changes. But a couple of other things, and that I think you've all mentioned as well. Who's heard? Where are the voices that are not heard, and can we include them? And sometimes it's including them within the discussions and panels. But I work with children, and it's not right to put a young child on a panel like this. But can we engage with them so that we can actually understand what they think and what they understand and what they face? And you can do that. You can do that in different ways, but you can get those voices in. And of course, as we've discussed, there's voices in other parts of the world that are often ignored, as has been said. I do want to talk just briefly about some of these very divisive policies, and those are everywhere as well. Increasingly, there are populist policies, populist rhetoric that creates these environments that marginalize, victimize, persecute people. I talked before about the hostile environment towards migrants in the UK. We have a recent policy called the Rwanda policy, where asylum-seeking people coming to the UK are sent to Rwanda, and they're sent without assessment. And I also find it astonishing that I'm saying this, that this is one of our government policies, and it's going through legal challenge at the moment, so we don't know quite where it's going to end up. But this is incredible that we are trying to do this kind of policy in the UK. I just find it astonishing that I'm even saying that. And then how do we build awareness? So I think using some of the platforms that we have, using the positions that we have to talk about these issues, to discuss these issues, to explicitly call out these issues, as you've said, and then also to give the voice to other people. So sometimes moving aside and let other people speak. Sometimes it's getting those understandings of voice and transmitting them. And we've tried to do that through our relational health groups, tried to have different ways of engaging through art, through audio forms, podcasts and webinars, and different ways of doing it. So there are lots of different platforms you can use. And increasingly, younger people are very good at using those platforms. And maybe it's other groups, it's artists, it's activists, it's community leaders who are actually much better than that, than people like myself. I think I'll end there.
Thanks for that, Dylan. And then bringing in the issue of children and young people as well, and racism and confronting that. And I was hoping you would speak about that, and I hope we can build on that a bit further. But something that did struck me, particularly from your remarks, was how much normalized racism and xenophobia has become. The policy in UK is not starkly different from the one that Australia has been implementing, with sending asylum seekers and refugees to Nauru for a while now, and we've got colleagues who can speak to that. And this has almost been forgotten, that because it has been so normalized in that rhetorical sense. Over to you, Anna. Your thing.
Yes, thank you for that great question. And I think we start by having these difficult conversations, right? And this is why it's really wonderful to have this type of panel today. Obviously, it's really easy to speak with like-minded people who are interested in addressing racism, but it's really stepping outside of our bubbles and including those people who perhaps don't understand that this is an issue because most likely they're not affected by it. And so I also agree with my fellow panelists that we need to do something at all levels. And I really loved your graphics showing that. At the local level, we do need change in terms of policies, laws, but also we need to not only enact those laws, but include the affected communities in that policy development, in those policy discussions. But obviously that requires an openness from governments and from policymakers. So related to that, we also need to have greater involvement of civil society in terms of really raising this as an issue. And this also includes obviously a measure of activism that really needs to happen at the grassroots level in order to really enact that change in the long term. I did speak about research in my remarks a little bit, and including those affected communities and that local knowledge in developing that research. And I think that needs to happen at all levels, both at the local level, also at the international level. I actually was involved in a project where we used a participatory method among policymakers in a region in South America. And it's not easy. Any participatory approach is really complicated in order to bring people together to have these ongoing discussions. But especially when you bring into the fore politics and obviously competing interests, it becomes even more complicated. But there are ways of managing that and doing that. So again, stepping into really having those complicated conversations at all levels is really important. I also discussed, and you also mentioned how we need to rethink a little bit about how we fund global health, what we fund, and how we develop those priorities. And so a lot of that involves including those voices at the table, but not only, again, governments, but also affected communities, which I think there is much more openness towards that today, but considering not just specific civil society that traditionally has been involved and included, but also looking outside of the box of who else needs to be included. So those are my remarks for now.
Thank you very much, Anna. And I think this idea of needing to address the different layers and different levels of it, but also the recognition of the fact that this is a long haul that we are talking about. There are no easy fixes because these are difficult conversations, and these are conversations which unfortunately have gotten much worse. The floor is yours now, open to the audience, please, for your questions, comments, reflections as well. I have a few hands already, started with colleagues in the front, in the white jump. Shall I help you? Oh, the microphone. Thank you.
Hello, everyone. My name is Christelle, and in thinking about the conversation, one of the things that came to mind for me was health in all policies, and how that plays into the big conversation about structures in healthcare and how that affects in racism, but structural racism and also structural healthcare. So my question is, how would you say policy surveillance has been in regards to policies outside of healthcare which affect healthcare, and how can that be improved? Any recommendations for that?
Thank you. I'll capture a few of the questions and then we come to the panel. Yes, the lady at the back. Oh.
Good afternoon.
One more and then come back. Yeah.
Good afternoon. Thank you for your presentation. I was really excited to see the socio-ecological approach to tackle the structural racism. However, I was disappointed to see your 6-point call for action that there's nothing about poverty. And really, I wanted to ask about in your perspective, how really structural racism shapes poverty? Right. Because it's an urgent issue and that's not talk. And we have sustainable development goal, #1, eradicate poverty. So if you can talk about that, thank you.
Thank you. And there was one more question at the back. In the corner here. I thought your hand was. No.
Claire's hand was up.
Yeah. And then we do the second round. Okay, we start.
Thank you. I just wanted to ask about, you mentioned decolonization, and in one of the earlier sessions today, somebody had been expressing skepticism about decolonization as just kind of the new colonialism, it being perpetrated by the same actors. So I'm just wondering if you have any comments about that.
Of course, that would be an interesting one to explore. Given that my institute houses the whole program of work on decolonization and global. I'm going to come to the panelists, but Ghaffar, I don't want to put you on spot. There is a question which I think you should also take, which is about systems for health and what is happening in systems outside health system on these issues. And as a former director of Alliance, I think you should take that one as well. But maybe I start with the panel.
Okay. Actually, would you like to go first? I feel like we always go
Sure.
like one
Yeah,
direction
that's
versus the other.
completely fine. So you, Christelle, I think spoke about health in all policies and how we can look outside of health sectors. So obviously, economic policies are a significant part of this, and it's really there that we need to rethink. I mentioned austerity measures a little bit in my remarks, but also rethink whether these economic policies, who are they for and who do they affect, right? And so really holding our politicians and our decision makers to account into what type of economic decisions they make, because we do know that some economic policies actually have the inverse effect of what they originally were trying to do. Also, in terms of social policies, obviously, Delan mentioned important issues around migration and how that also can perpetuate racism, and the way that migrants are being portrayed in the national discourse is really important, being able to address that. And I would also say another part of the social policies is looking at inclusion and how we define inclusion and who do we include when we're thinking about that. A lot of times inclusion is seen as including certain populations, but race is really ignored, and other factors are very much ignored. So thinking a little bit outside the box in that. And then I'll come back to the other.
Thanks. And maybe I'll respond to the comment on poverty in particular. So the relationship between racism and income and wealth is, a very strong one in the structural racism. Affects the kinds of jobs that people get, which affects their income, which affects their long-term wealth that they can pass on to future generations and so on. Is poverty important? Absolutely. Absolutely it is. I think the way that we design these principles were that these are the things that can help support people, particularly with health outcomes, but of course would improve someone's life chances, improve their, if we take a justice approach, for example, can we improve the kinds of situations that people in, try to improve their employment, try to improve their wealth and income. If we take the decolonized approach, maybe I'll defer to Roger for that one. But hopefully those kinds of principles tackling some of the structural forms of racism can improve the situations that people live in, can improve their health outcomes in particular. But do we have to act on poverty independently? Yes, of course we do. I mean, I'm not denying that at all. Thanks.
Thanks. All right, so I am interested in Christelle's question about health and all policies, and the thing that comes to mind for me is climate or environmental policies and the ways that they clearly, the data show, have an effect or differing effects on communities depending on a number of factors, including race. We actually in our department established at the start of this administration or close to the beginning of it, an Office of Climate Change and Health Equity for that reason, looking at those intersections. And it's building on work that CDC and NIH actually were doing. So I want to give them credit, quietly, right? But lifted that up to really be more featured. And it has not yet been funded by our Congress, and yet it's still a really helpful and important policy frame that we use in our engagements at the COP or, at World Health Assembly, right? On the decolonization piece, and I would love to hear your response to this, because I've heard that too, and so I wasn't entirely surprised by the question. I say, look, I mean, if that's happening, well, if that's happening, then there's, I think, a very real opportunity for people who really know what decolonization means or is meant to be to hold people's feet to the fire. It's like, okay, well, you want to own this? I mean, we did this with Black Lives Matter. It's like, oh, so by the way, you know what we mean by that? We mean this. So that's what you should be doing. So I think with decolonization, it's like, all right, you want to own it. You're excited about it. Here's how we define it. Go forth and make it happen. And we're going to be watching, right? Like that's, I think, the way to respond to that. Because I wouldn't want the community who has championed this so well to feel like they have to fall away or find some other term or approach, or it's like, it's here, people are paying attention. Let's use the energy that you all have created to steer it in the right direction.
Well, that sets me up rather well. I will tell you my understanding of it and how we are approaching this. For us, the framing of coloniality is essentially a representation of an extractive nature of relationship between global North and global South, which has been perpetuated by patterns of how colonization essentially took place and how power structures and power asymmetries have been determined. The way we come into the conversation around decolonization and coloniality is essentially how do you shift power in global health? So when we talk about colonization, we talk about it in three parts. We talk about decolonization of global health. We talk about decolonization through global health and decolonization in global health. So I do appreciate where the conversation or the challenge comes from and whether colonization is the framing ripe enough to capture all kinds of power imbalances and asymmetries that exist or do not exist, especially as somebody very rightly once said in a conversation to me, there are pockets of global South and global North, and there are pockets of global North and global South. The system of elitism in global South are very profound. We work through different natures of hierarchical structure, whether they are caste, religious, class, and so on. The question I often pose back is that, labeling is important. We need to, but the way the conversation on colonization is happening is almost as a metaphor to address the power asymmetries and imbalances, whether they are within countries or between countries. But the question hinges upon is how do we understand and address the power balances? Before going back to the next round of questions, I did wanted to come to Dr. Abdul Ghaffar, the former director of Alliance for Health System Policy and Research, for the question on health in all policy and how do we address this?
Thank you, Rajat. But I think you have prompted me, so may I make another comment on decolonization?
By all means.
Okay. See, this was a colleague when I was on the panel, she asked the same question for the decolonization. And what you are saying is, it's a power structure. And let me give you, because I was in the global health for the last 25 years. In 1992, the capacity to generate local knowledge in South have not changed since over. There's some change, but if you look at the per capita, the per scientist, and the allocation resources has not changed over the last 30 years. And nobody is willing to invest, including where we were working both in the World Health Organization. There are 4 research departments. They were primarily established to strengthen the capacities of researchers to generate and use policy relevant knowledge. And if you look at the trend line, and I think that is, if we want to move to decolonize, we need to change that. We need to have a more investment, not in Hopkins, which I'm very proud. And we all went there, most of us, like Hopkins, Harvard, London School of Hygiene and Tropical Medicine. We need to give the endowment, and trust me, people are much more brighter than the people at Hopkins, Harvard, and London School. But that is the decolonization, not what we want to write another special issue on decolonization by the Lancet.
Yeah.
And I think that's a good thing to do. But then the second thing for which you are kind to ask me, I think there's a mindset, there's a flaw in thinking how the health systems are designed. I believe all of you have gone to the schools of public health. We are taught it's a linear model, input, output, outcome, impact. And we all love it because it's perfect. Again, apologies for the economists. It's perfect for the efficiency and effectiveness, but it's useless if you want to look at the readiness of the health system. If you want to have the health systems, then we need to move from the discussion, either we call health in all policies, whole of the government, whole of the societies, or systems for health. If we want to have the systems for health, which was the last report we published before I left, then the racism, and there's a lot of determinants which are very, very important, even when you have to look at the absenteeism, when you have to look at the outreach facilities for the vaccination coverage, when you have to have the family planning services. These are all part of the systems for health, not health system, because health systems are all verticalized. And that's what we all do, either in London, DC, or Geneva. We create silos and boundaries, and then we try to see, we don't know why these things are not happening. We all know why it's happening. We are trying to have more sophisticated models, which are very well, but I think there's nothing which is really coming for policy relevant, which can help to the policymakers, managers, and program implementers, that this is the way to do it. But I think we are a long way to do those things. So I think definitional we can discuss. It's a mindset. I think one of you, either Louis said or you said, it's a shift or the change in the mindset. If we don't do it, we can have a lot of sessions, a lot of summits, a lot of World Health Assembly. Things are not going to change.
Thank you, Gafar, for that, and then congratulations on your last hurrah. Zorafa, Marlene Temmerman over there has, I think, a reaction immediately to this. So let's hear from Marlene, who's also my former boss. So otherwise,
so I have to comment, right? No, I think, sorry, the definition that you gave was great. Intellectually suitable for a director of your institute. That's what we need. But I agree with Ms. Pace that if you want to explain what it is, you have to find something very simple that everyone can understand. So it's like with feminism. When I'm teaching and I ask my students, who is a feminist? Medical students, about 22 years old. There are a few who lift their hand, you know, a few girls a bit, a few boys. If you then say, well, it is exactly fighting for the same rights between men and women, women and men, girls and boys, and you give some examples at the end of the class, 90% is agreeable. So what I'm trying to say, we have to find a very simple wording that if we use the word, that we can kind of have a subtitle or a very short sentence, how to bring it over, and so that everyone understands.
Thank you. Thanks, Marlene, for that. And I think indeed, if we are going to get anywhere, we need to have more people as part of this journey as well. I think we have enough time for one more round of questions, and I'm going to try and be as inclusive as I can. We did have the lady right there to start with, and then I've got you on my left, and then Nagesh, and then we will try and come back. There's somebody at the back? Okay, great. Please, over to you.
Claire Wingfield. Thank you. This panel's just really wonderful. And my question changed as the round of answers came around. But I'll be honest, I do find this so overwhelming. We're talking about huge change, which must, I think everyone here would agree, needs to happen. And so I have a kind of, fairly simplistic question, I hope, is, are there any like concrete examples, no matter how small the impact, or whether it's on the individual level, the group community level, is there an example of, using anti-racist approaches that we could say has shown some kind of impact, if it's on access, health outcomes, which might be a little too long in the future to measure, but I just would love to hear of an example on something inspiring that also makes this feel kind of doable. I know I can do things sort of my own individual, but that's things that can have really more reverberations.
Absolutely. Can we?
Hi, everyone. My name is Sandra. And so before I even ask my question, I had some reflections when you were talking. So when I think about structural racism, in my mind, people make the system. We are the system. We make the policies. So if we make the policies, and let's look at health systems, for instance, to your point, Black mothers having worse adverse outcomes postpartum, or even during the pregnancy, right? And a lot of them talk about discrimination from healthcare providers. This is the reported information out there. So for one, I'm thinking, okay, if we begin with thinking maybe the providers don't know that they are racist, or they're prejudiced against this minority. Then we go into the conversation of increasing awareness. Now, in increasing awareness, what if someone is able to identify that, oh my God, perhaps I am prejudiced? How would they feel safe enough to seek help? Do we have that safe space for a healthcare provider to say, I think I may have some issues. What do I do? Because I think that the reluctancy comes from the fact that, oh, I could lose my license, or I can't practice anymore. So how can we create that space for them? And I think there's a provider on here. What would you need? And this question is for any provider in here as well. What would you need for it to be a safe space for you to admit that, yes, actually, I think I have these issues. How can I make it better without having the fear of losing their license or not being able to practice? And another thing, another outcome or result of the structural racism against minorities is that now when a Black woman is seeking healthcare, they're more likely going to look for a Black physician, and in this situation, isn't it encouraging another form of segregation? This is just my own reflections, and we can talk about it.
I'm going to talk about the glass is half full, and kind of see if we can talk about the positive sides of it. I guess, can we look at the success stories and, also bring those examples out where things have been done in a positive way, right? Are there examples of healthcare facilities being safe space for everyone to access, right? I was in, for example, the DR, right? The Haitian mother cannot go in the DR health facility because she is afraid of getting deported, right? So are there examples where this doesn't happen, where there's no, limited to access because of your race? I think that's one thing. The other thing is, are the example of healthcare workers being trained to be open to anyone and everyone with equal access, right? Because there are examples of even healthcare workers discriminating who is coming in the health facility. So I think maybe we need to look for the positives examples and maybe talk more about how the narrative can change towards what is possible.
Thank you. Thanks, Nagesh, for that. Anna, may I start with you and then we go this way to the panel and conclude?
Yes, thank you. Really great questions. And I think I'll start with the question about how do we create safe spaces? And I think it starts by recognizing that all of us are biased in some way, and that we, in the process of examining and reflecting on our practices, especially as possible providers. I'm not a provider, I'm an academic, but I'm also obviously very aware that I'm highly biased, and starting that conversation, I think, is really important, and creating practices where there are ways of anonymously reporting things, but also anonymously seeking help and seeking community in order to discuss these issues. So I think we would start by that. And then it's also an interesting question about people seeking providers that look like themselves, and whether that is a way of perpetuating racism. I think that's a complicated question because obviously patients who are already in a situation of vulnerability will seek providers that they feel will not discriminate against them. So it's a bit of the chicken and the egg of how do we make sure that these populations receive culturally appropriate care in a scenario, in an environment where we know that is not always possible, right? We don't live in a perfect world where we know certain hospitals or clinics are completely devoid of any type of bias or racism. But I think eventually that could be a future, but perhaps it isn't what we can see now. And then I think examples of things that work, there are a few examples out there, again, by starting at the provider level. And I think providers have millions of trainings, and all of us take these DEI courses. But what really sticks, I think, is putting the providers in a situation where they're able to relate to people of different backgrounds. And I think COVID-19 was an interesting example where in some communities, we were probably all experiencing significant loss and significant harms, and understanding that in a lot of ways we are very similar. So I try to be an optimist at all points. I know maybe it doesn't always come off that way, but how can we use those little windows of opportunity to really enact change?
Thank you. Can I give a couple of examples of things that might work? And two things come to mind. One is a child development project, and the other is actually on the question of decolonization and funding. So one example I'd like to give in an intervention that did work was it was here in the US, the Abecedarian project that looked at early child development, and this targeted a community in the US, predominantly poor community, predominantly Black community within the US, but did a number of interventions for young children, quite intensive interventions, so really focused on child development and in many different forms. And they followed up those children, and 2, 3, 4 decades later, they found health benefits in those populations where we intervened early in life, with the return on investment about 2-3 times the cost of what the intervention was. So these kinds of interventions can improve health outcomes. These can improve long-term health outcomes, but you need to almost have that foresight. And maybe a question I might put to my colleague here is, how do you convince a politician to invest? Because you talked before about we don't get points for that. How do you have an incentive structure where you do get points for not having a heart attack in 20, 30 years.
Mhm.
The other example is actually quite a small one, and this is about funding in the UK. So the biggest health funder is NIHR, National Institute for Health and Care Research, and they started global health funding about 5 years ago. And initially, when they started, the funding had to go to a UK institution. So I got one of those projects, and I was the person. So the funding came to my institution, and then it went from my institution to partners in this case to India, Afghanistan, and Sri Lanka. A couple of years ago, NIHR changed their policy. So now that funding can go directly to a group in a low middle income country. And I was part of an application where the lead investigator was based in Sri Lanka. And I was co-investigator with a few other people from the UK. And that whole structure changed because that money went to, well, we actually didn't get the funding in this example, but hypothetically, that funding would have gone to the partner in Sri Lanka, and they would have controlled it, and they would have made the primary decisions. And I was sort of peripheral in that organization. So that's a very small example, but you can change these things. And then on the question of safe spaces, and this is difficult. I mean, this goes beyond racism to sort of medical negligence much more broadly. Whistleblowers traditionally have not done very well. Systems have resulted in those people who call out issues being pushed out themselves. So I think there are issues of overt acts of racism from health workers that exists, and health workers are members of the population. So that's not unusual in that respect, but some of this is not actual overt discrimination. It's sometimes a misunderstanding even of physiology and biology. So these ideas that we come up with, the fact that races are a social construct, even that isn't very well understood by health professionals, by medical colleagues of mine. We talked about one example. So we did a podcast on this about renal race corrections, where different corrections are added for Black people. And this is something that happens in the US, in the UK as well. And there's no basis for this. And increasingly, renal physicians are challenging this, and these algorithms are changing. But some of this is just built into medical training, built automatically in some cases into the lab systems where you correct the renal function of a patient. And those are racist systems that have perpetuated, but it isn't the individual doctor who may have been taught something different, maybe just get a report that is different. So some of those systems we can change.
I like these final questions. Thanks, everybody. So I'm going to try and I keep doing this. Sorry, guys in the back. I'm going to try and tackle Claire's question about positive change. So one, I'm really glad that that we spoke about Black maternal mortality in this country. Abysmal. We in the department knew that was a problem even before this most recent data. And what we did as part of our, sorry, I think I'm getting feedback on this, as part of our efforts to tackle this is we, through our Centers for Medicare and Medicaid Services, decided to do a few different things. One was to grant awards to hospitals and maternity centers to collect the data on this problem, right? And so, like I was saying, you got to say it, you got to see it, you got to solve it. And by making those awards, right, it's like, okay, well, then you see what we see at the very least, right? And we'll give you credit just for looking at it, let alone, what you can do then once you collect that information. We've also expanded our coverage to include doulas, because we heard from Black women that that's what they need. I mean, I moderated a very powerful panel during last year's Black Maternal Health Week, where to a T, each of them talked about having someone who could guide them through their experiences, which were really quite rough. And if they didn't have those people navigating the system or that experience with them, they might have had worse outcomes. And so we did make a decision, not just based on that panel, but based on data to support those that cadre of health providers. And then we also have expanded the availability of postpartum care for similar reasons, knowing that that's where we see a lot of these poor outcomes again for this population. And I will say, notably, the head of our centers for Medicare and Medicaid services is a Black woman. Right. So like back to the people who make these decisions and understand these experiences, I think that is just important to call out. Another example that I want to take a bit of time to not a lot of time, but just I want to be sure and mention, because I think it's quite powerful, is through our Administration for Children and Families and the way that they work with Native communities. And so they, after, a lot of engagement with these communities, and again, working with people from Indian country, they've decided that they need to reframe their narrative around research and evaluation. And so they talk about indigenous ways of knowing, not just scientific rigor, but also cultural rigor, sharing of knowledge, right? Like, and that to me, I mean, even those little tweaks can be so powerful. It's like, yes, that's it, right? Like that you got to show up and even just approach this problem in a different way. And then that way you can solve it differently. And just quickly on this question of, are we resegregating? I mean, I don't know who else in here has this experience, but I'm part of the first generation in America born with full civil rights. So my parents were born into segregated societies and lived through them, but as did aunts and uncles and the like. And I imagine that for my mom, I mean, she couldn't even be born in the hospital because there wasn't a Black hospital. She had to be born at home. So, and my grandmother lost children as a result, right? My mom survived, thank goodness. I, of course, and I shouldn't say of course, but thankfully did not have that same experience. But I think we were both happy that I had the option, and she later had the option to have Black providers who understood her. But I think she saw it as progress that those providers existed in places where she lived and worked. And so I think that's the distinction. And I think it's a similar question that people have asked of education, right? Like if kids only have, in my case, Black teachers, is that resegregating? And my mom would say, no, because she's going to school down the street. She doesn't have to, walk 2 miles like I did, and not get a ride on the bus or, sit in a different place. So, that's just a little bit of perspective that I offer. But I, like Anna was saying, really appreciate the question, because, we should be doing no harm in any of these solutions as well.
Thank you. Thank you very much for that, Lois and Dylan and Anna as well. I'm not going to try and summarize a conclusion in any way whatsoever, but just some thoughts to end our conversation today about, because this certainly is not a conversation that we are ending today. I think I speak for all my co-panelists that this is a conversation that is just about starting. The killing of George Floyd in this country did something not only in terms of how we understood issues around racial matters in the United States, but also around the world. It forced us in a way I don't think any one of us was expecting to have these difficult conversations. I remember I was working at Amnesty International's International Secretariat in those days when the killing happened. And one of the first points of realizations for us was, we are a racist organization ourselves, and that we need to start by addressing our own racism in the way we function and what we as an organization represent. So the first takeaway from this conversation for me today is what, Lois, you started this conversation with, is we need to start by recognizing we have a problem. Because that's when we start getting to a point about what do we do about it. And surely it's not easy. Surely there are no simple answers that one can be done. But if we start recognizing that we have a problem, I think the next step for me, as was becoming clearer in the conversation and through our discussion, is that we need to also start recognizing our own power, privilege, and biases that we come with. It might manifest itself in different ways, explicit or implicit, but they are there. And through that we tend to appreciate not only within the interpersonal space that we work within, that brilliant schematic that Dylan presented to us, from individual to the community to the spatial, but also we tend to try and identify ways to address and dismantle those power relations that exist. I think in global health today, we stand at a cusp. There are conversations going on, which people like you are shepherding in terms of what kind of a new global health architecture should be there. We are looking at the pandemic accord. We are looking at the 100-day challenge, the fund, the everything else that follows from it. And I think it's a great opportunity for us to not just reaffirm and tweak the systems that there were, but actually reset and rebuild. Because I think, Dylan, you pointed out, and Anna as well, who's making the decisions? For whom those decisions are being made? And then are those people on the table? And how do we get them on the table? Because unfortunately, those are hard questions. And there will not be simple answers. But what we do have is an opportunity here to at least make an attempt to get to those conversations. It's a journey. It's a marathon and probably much longer, but I'm very glad you all came for this conversation, for the audiences online who joined us, but also particularly to my panelists for taking time to come here. Thank you so much. Thanks a lot.